Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Professor Ramin Tadayoni of the University of Paris, where he is professor and chairman of the Department of Ophthalmology. Ramin, welcome to Retina Synthesis.
Thank you, Carmen, for the invitation. It's a pleasure to be here.
You gave an outstanding talk at the Miami Angiogenesis meeting examining Faricimab for the treatment of retinal vein occlusion. Can you tell us about the study design?
Sure. Thank you very much. It was indeed a wonderful meeting, and I presented the result from Balaton and Comino, two global randomized double-mask active comparator control phase 3 trial for Faricimab in RVO. So basically, the design is very classic design. So 6 injections of the drug in branch vein occlusion in Balaton, in CRVOs in Comino, and compared to 6 injections of aflibercept. Injections are spaced by 4 weeks, and the primary endpoint is 24 weeks after the beginning of the study. That means 4 weeks after the last injection, the 6th injection. After that, we are waiting for the result. We have the primary data here, but after that, there will be a PTI, so some kind of treat and extend that will go up to 72 weeks. And then we will have the end of the study at that time, and we will have the result later on this phase.
So after the 6 doses, what was done?
So after the 6 doses, so patients were compared between Faricimab and aflibercept group. Again, Balaton in BRVO and Comino in CRVO. And it was first checked that if the demographic and the K baseline characteristic were well balanced, and it was the case. And then it was tested if the Faricimab groups were not inferior to the aflibercept group. And it was confirmed that both of them were non-inferior in terms of visual acuity to aflibercept.
So these were the 24-week results, is that correct?
Exactly. That's exactly that.
And what is the plan for personalized treatment interval with Faricimab?
So after that 24 until 72, there will be some kind of treat and extend. So there is a refined or improved treat and extend regimen that will be used only, all patients will have Faricimab. And then it would be possible to check how it's possible to increase the interval of injection, how many injection patient needs, so to be able to show the durability of the drug compared to what we have today.
What about the OCT changes? Were they similar?
So OCT changes were similar. So both of the drugs, they decreased the thickness to quite normal, and in CRVO and in BRVO cases, and they are very, very similar. They are so similar that on the slide that I showed in Balaton, it was even not possible to distinguish the two values. But in the FA, there was differences if you choose another modality of imaging.
What were the differences?
So in FA, there was a pre-specified exploratory analysis, which was to look at the percentage of patients who achieved no leakage on FA, saying that probably they will have a better stabilized vessels, non-leaking vessels. And in Balaton, as in Comino, there was more patients that achieved this absence of leakage. There was 33% in Balaton compared to 20%, around 20% as far as I remember for aflibercept, and in Comino, something like 45 to 30 also. So this shows that there is no leakage from the vessels, so they seems more stabilized, which is one of the goal of adding Ang2 inhibition to VEGF. It could stabilize the vessels.
So what is your current treatment protocol in Paris for vein occlusion?
So we do a loading phase that we inject at least 3. Sometimes if there's several cases, we go to 6 injection as it has been described. So 3 to 6 injection in row. And then we try to increase the intervals as much as possible. So some kind of observe and treat, or treat and extend, or PRN, depending on doctors and patients. So I try to give a view of different practices in Paris.
So, and how long is the treatment period? The SCORE trial implied that treatment needed to go on for 5 years at least.
Yeah, I think there's a percentage of patients that after 4 years, you can stop. But many of them you go beyond. So if you make an average, it may be something like 5 years of treatment. So some of them, they need treatment forever. But in France, we use a little bit more steroids that you may use in US. So when there are patients that need a lot of injection for a long term, sometimes some of them are switched to steroid to increase the interval. So here, if the Faricimab, it's possible to increase the interval, that would be another possibility. Because as you said, it's a long-term, lot of injections.
So you use the dexamethasone implant for that?
We use, yes, more than in US, probably. Especially if the patient is pseudophakic with a low intraocular pressure. Not at the beginning, not often. Some people use, but not often. But when you have patients that needs monthly injection after 2 or 3 years, at some points, they ask for increasing the interval.
That is interesting. What is your anti-VEGF agent of choice?
So in France, we have Lucentis and aflibercept. That's the only choice we have. So we use one of the two. Today. We are waiting for others.
What do you think about Faricimab as going forward in the real world?
I think if we want to stay in BRVO and CRVO, we have to wait to this PTI phase to see how it can increase the interval of injections. So at least in these two studies, it seems safe. It seems as effective, at least as aflibercept, and we'll see if it enabled to increase the interval beyond what we are used to. That will allow to use this anti-VEGF since the beginning and then have less injection in our patients, which is what they ask.
When's the next data readout?
So it will be at the end of the 72 weeks. So not tomorrow.
Not tomorrow. Ramin, thanks so much for your wonderful discussion. And
thank you, Carmen.
Our audience, and we have 73 countries that listen to this retina synthesis. So, and we have listeners in France. So thank you so much.
Thank you for inviting me, and thank you for doing this.